we can also use artificial intelligence to help us with the treatment of breast cancer.
This is the James Cancer-Free World podcast. I'm Steve Wartenberg, and my guest is Dr. Aria Roy, a James medical oncologist. Aria specializes in treating patients with breast cancer, and her research focuses on better understanding and utilizing immunotherapy. Artificial intelligence is being used more and more in medicine, and Aria will fill us in on how it is being used to assess the risk and recurrence of different types of breast cancer, which will help more and more women and men too screen for and detect their breast cancer in their earliest stages when it is much more treatable and the outcomes are better. Welcome to the podcast.
Thank you so much.
So detecting breast cancer is vital because, as I just said, detecting in the early stages, the outcomes are so much better. So give us sort of an overview of what women need to know, the basics of screening for breast cancer.
Sure. That's a great question. So breast cancer is the most common type of cancer in women, and it is the second most common cause of mortality or death associated with cancer in women. According to the statistics, in the United States, it's projected that in 2025, there will be almost 300,000 new breast cancer diagnoses. So it is very common in women. So we need to understand how we can identify the breast cancer in the earlier stages. Because we know that from the data, if we can identify the patients with early stage breast cancer, then their prognosis or their outcomes are better. Studies actually tells us that if we identify the breast cancer in the early stage, 90% of the patients live without any breast cancer diagnosis for more than 5 years. But when it comes to the metastatic stage or stage 4, the outcomes of the patient, it actually goes down, and there is a higher risk of mortality in stage 4 breast cancer. So it's important that we need to identify the patients with breast cancer as early as possible. And that's where the utility of screening techniques comes into play. So as we know that the most common tool that we use for identifying the patients with breast cancer is mammogram. So we need to do mammograms starting at the age of 40 years, and we need to do that annually, which means every year we need to get a mammogram if you are 40 years or above. This is
for women with normal risk.
That is correct.
Okay, you're going to get to high risk, but sure. Women with normal risk start every year at 40.
Yes, that is correct. According to the new guidelines, if you are not a high-risk breast cancer patient, you can start getting mammograms at the age of 40 years, and you need to repeat that every year. But there are several women who have high risk of having a breast cancer. For example, if you are a patient with a family history of breast cancer, and if your mother or if someone in your family had breast cancer, then you are always at high risk for developing breast cancer. And if you are someone with dense breast or thicker breast, also there is high risk for breast cancer. And if you are someone with some genetic mutations, such as BRCA1, or we call it as BRCA, so BRCA1 or BRCA2 genes, these are actually genes which are strongly associated with breast cancer and ovarian cancer. This will also cause several additional cancers, but BRCA is always at high risk for breast cancer. So if you are a patient with these genetic mutations, that means you are always at high risk for breast cancer.
So if someone has a big family history, mother, aunt, grandmother, they might be genetically tested to see if they had that BRCA1 or 2, right?
Yes, that is correct. We always advise patients to be seen by a high-risk breast cancer provider or someone who specializes in high-risk breast cancer. For example, at the James, we have a high-risk breast cancer clinic.
Yeah.
So if a patient has a family history of breast cancer, or if the patient has a history of radiation to the chest wall, for example, if you have a personal history of a cancer such as a sarcoma or like Hodgkin's lymphoma, then it sometimes involves radiation to the chest wall area. So radiation to those areas also make you prone for having breast cancer. And also if you are someone with like family history of breast cancer, you need to see a high-risk breast cancer provider so that they can refer you to the genetics team so that we can check the mutations. Mutation means we can check if you have any mutations in the bloodstream that you actually got because of your family history. There are several genes. One of the genes is, as we mentioned, BRCA1 or BRCA1, then BRCA2, then there is PALB2 gene mutation, CHEK2 gene mutation. These are several mutations that is associated with the risk of breast cancer in addition to several other cancers. And all these mutations are actually detected from a blood test that you can get through the genetics provider.
Wow. So if a woman has BRCA and gives birth to a girl or a boy, that child would have a 50% chance of having it?
We cannot entirely say that it's 50% chance because there is always a high risk that the child or the offspring can get that mutation from the mother. But sometimes even if the mother doesn't have that mutation, if they had any any person with that same mutation in the family, there is always a chance that
it can skip.
Yes, it can skip some generation. So it doesn't always mean that there is 100% chance or 50% chance. But if there is any family history of BRCA gene mutation in the family, then you need to be seen by a genetics provider so that we can do the genetic testing to see if you have any of these hereditary mutations which can cause breast cancer.
And people who have that would be tested sooner than 40 and a different test?
Yes, that is correct. So all the patients which we mentioned, patients with BRCA mutation or any genetic mutation which makes them to have breast cancer and makes them more prone to have breast cancer, or if patients with the history of chest wall radiation or any family history of breast cancer, these are actually high-risk patients. In patients with high-risk breast cancer, we don't have to wait until 40 years to get the mammogram. You can actually start doing mammograms at the age of 30 years and above if you are a high-risk patient for breast cancer. And in addition to mammogram, and especially if you are a younger patient with a family history of breast cancer or these genetic mutations, we need to consider during MRI of the breast. So we always start the MRI of the breast at the age of 25 years or above for patients with very high risk of breast cancer. So in younger patients, we always combine annual mammograms along with MRI of the breast.
So what does the MRI do that the mammogram doesn't, that it can detect something that the mammogram can't see?
Yes, that's a great question. So mammogram is an X-ray of the breast. But X-ray always have several limitations because it's just a superficial imaging of the breast. Even if we have the 3D mammograms, it is not completely sensitive or for detecting the breast cancer, or sometimes you can actually miss some small breast cancer or some small mass in the breast in the mammograms. So when we do the MRI, it's actually a magnetic technique, magnetic resonance imaging. It's a longer test. It's not like a mammogram where it's only an X-ray. You may have seen the MRI machines. So in the MRI machines, they will actually use some magnetic waves to identify the images, to identify the structures in the breast. So it's always more sensitive. It's a time-consuming image, but it's always more sensitive than the mammograms in detecting small breast cancers. And here we need to talk about another type of the breast cancer, which is called as lobular breast cancer. The most common type of breast cancer is ductal breast cancer. But the second most common type of breast cancer is called as lobular breast cancer. And lobular breast cancer is seen in 10 to 15% of the patients. But we need to keep in mind that it's very hard to diagnose lobular breast cancer from the imaging, from the mammogram technique. And this is another space where we utilize the MRI of the breast, even if the patient does not have a high-risk feature. Lobular breast cancer is commonly seen in patients who are elderly or more than the age of 60 years, but I have seen several lobular breast cancer with the age of 40 or sometimes less than 40 years as well. Whenever we see a patient, if the patient has a dense breast, and there is always a chance that you can miss some small mass in the mammogram, especially if it's a lobular breast cancer. So it's always better to refer the patient to get a bilateral MRI of the breast so that we can identify cancers like lobular breast cancer which can be missed in the usual mammogram. Because lobular breast cancer does not usually form a lump. When we think about breast cancer,
right,
all patients think that it's a lump, right? But lobular breast cancer, it does not have a protein in the cells which actually keeps the cells together. And as that protein is called as E-cadherin. So as the lobular breast cancer cells, it doesn't have the protein to keep them stick together. Instead of forming a mass or a lump, this lobular breast cancer actually forms a file or a sheet. So you won't see a mass in the mammogram. Instead of that, you may be seeing like there is an area of thickness. There is an area of thickness in the breast, or you may feel like the mammogram looks a little bit cloudier or a little bit cloudy when compared to the usual other mammograms. So in those cases, you definitely need to get an MRI of the breast, even if they don't have any other high-risk features, just to make sure that you're not missing the lobular breast cancer.
Okay, I have a couple biology questions
Sure.
that I want to make sure I understand. So you've mentioned a couple times dense breast tissue. What exactly is that? And can women know if they have it by just touch, or how do they know?
Sure. This is usually identified in the mammogram. If you get a mammogram, and in the mammogram, they will always mention that you have a very thick breast or a dense breast, or you have heterogeneously dense breast, which means that some part of the breast is thick, but some part of the breast is not that thick.
And this will be important for women to know so that they just know in the future that they might need more than a mammogram.
That is correct. If you are getting a mammogram report, let's say you got a mammogram at the age of 40 years, but the mammogram is coming back saying like this looks benign, which means that there is no cancer in there, nothing suspicious in there. But at the same time, if the report is telling you that it's heterogeneously dense, you need to talk to your provider so that you can have a discussion to see if you need an ultrasound or an MRI of the breast to identify if there are any small masses that is missed by the mammogram.
Okay. And my other question, you talked about the two different kinds of breast cancer, ductal and lobular. So in the breast, what's the different biologies, the difference between a duct and a lobe?
Sure. There are different kinds of breast cancer. So one of the most common type of breast cancer is ductal breast cancer, which originates from the duct, from the milk ducts. And also, you know that in the breast, there are ducts through which the milk is coming, and also there are glands in which the milk is produced.
Okay.
So if the cancer is originating from the ducts of the breast, it's called as ductal breast cancer. And if the cancer is originating from the lobules of the breast or from the milk glands of the breast, that's called as lobular breast cancer.
And the ductal is the more common one.
Yes, 80% of the cases we see it's ductal breast cancer, but lobular breast cancer is the second most common type in terms of the histology or the biology, and it's seen in 10 to 15% of the patients.
And as you mentioned, since it's harder to diagnose, it might get diagnosed in later stages. So
exactly correct.
The awareness you're trying to give people right now is very important.
It is very important that patients or people should know about lobular breast cancer, because as I mentioned, lobular breast cancer is not very common, but at the same time, it's very hard to diagnose. And because of the fact that it can be missed in the mammogram, we unfortunately, most of the time, by the time we identify the patients, they are already stage 4 or they have a tumor which is more than 5 centimeter. So when the size of the tumor goes up, there is always a chance that the tumor can spread from the breast to the lymph nodes that's draining the fluid from the breast.
In your armpits.
In your armpits, that's correct.
Yeah.
So it's always the risk of the cancer coming back or the risk of the cancer spreading from the breast to other parts of the body goes up if you have the cancer involvement in the lymph node.
Wow. Okay, that was a great overview. And now I'm excited. We're going to take a quick break. And when we come back, we're going to see how you are at the forefront of applying artificial intelligence to help make it easier to detect breast cancer.
The best outcomes for treating cancer come from early detection and early diagnosis.
The James Cancer Diagnostic Center at Ohio State
is designed to provide rapid evaluation and a clear diagnosis.
We are transforming care by giving patients direct access
to cancer experts who study and treat cancer every day.
If you think you have cancer, the choice is clear.
Choose the James Cancer Diagnostic Center.
We're back with Aria, and let's get into how you're using artificial intelligence, AI, to initially detect breast cancer and detect reoccurrence or to predict reoccurrence of breast cancer?
We are actually using artificial intelligence to identify cancer from the images. Because when you get a mammogram, when you get an MRI, an imaging, a radiologist is actually looking at the images with the human eye. So sometimes you can miss some small cancer cells in there or some small mass in the breast if it's very small. But if you train an artificial intelligence model and if you are using that, it goes by the image recognition pattern. So with that image recognition, even if we are missing a small cancer in the images, the computer will be able to pick that up.
So the computer studies thousands and thousands of previous mammograms and knows which ones have cancer and which ones don't, and it learns all the tiniest little marks.
Yes, it works with the imaging prediction. So you're exactly correct. You are kind of like teaching the model, telling them upfront that this is how the breast cancer looks, or this is how an abnormal cancer cell or abnormal cell looks in the imaging. So then it will learn it, and then it will help us to identify the cancer cells. But of course, sometimes there are like so many cases in which the pattern is not exactly the same, and you definitely need a radiologist there to help you identify that. But this can definitely makes the workload better, and also
it becomes a collaboration.
Yes,
and
exactly.
You have an AI expert and a human expert.
Expert, exactly. Yeah, that is exactly correct, because here it can save a lot of time for us, and also it is also less expensive. For example, we have several studies in which some of my colleagues who actually works on the artificial intelligence models, they actually developed risk prediction models in breast cancer. So in breast cancer, even when you have a breast cancer, even if that breast cancer is surgically removed, there is always a chance that some breast cancers can come back if the patient has high risk features. So in breast cancer, we use some specific tools called as Oncotype DX or MammaPrint. These are some specific scoring systems that we utilize in breast cancer. And if the scores comes back higher, that means you have a high risk of breast cancer. But we usually test this from the actual tumor of the patients, and we send it for the Oncotype testing. That actually works with the RNA sequencing technique.
So the tumor's already been removed through the operation,
yes.
the mastectomy or lumpectomy or whatever, and then you save that specimen and do all that analysis to score it.
Yes,
okay.
That is correct. So like my colleagues, they actually developed a technique in which they can just utilize the slides of the patient, the pathology, the digital pathology slides.
What would be the factors on the slide that the artificial intelligence would see that would indicate a higher risk of recurrence?
Sure. I can maybe say that with the example that I'm doing with my research. So I'm doing a research in lobular breast cancer in which we are using artificial intelligence to identify the patients who are at high risk for recurrence. As we discussed earlier, lobular breast cancer is harder to diagnose. Because of that fact, it stays in the body for a long time. And even if it's completely cured, sometimes it can come back like a long time after the initial diagnosis. Even lobular breast cancer can come back 10 years or 15 years after the initial diagnosis, because those cells can be missed sometimes, and sometimes it grows slowly also. So with artificial intelligence, we are taking the digital pathology of the patients from the tumor that is already collected. It's not like a new biopsy. The biopsy is already done, or the tumor is already removed. So we look at the patient's pathology slides, and then we see how these cancer cells are behaving. And then we compare that with the other common type of breast cancer, which is the ductal breast cancer. So we can see how the slides of a lobular breast cancer patient, how is it actually different from a ductal breast cancer patient. Sometimes there could be rapidly multiplying cells, or some cells could be like looking very different than the other cells. And there will be some other cells like macrophages, or some other like T cells. In the slides, we can see that in addition to the cancer cells, they are also having like some other cells which are seen in the same slide itself. So with the artificial intelligence, you will be able to identify the cancer cells, or the immune cells, or the macrophages. These are the several other cells that are actually seen in the same slide, which might not be seen in ductal cancer. ductal breast cancer slide. So you can compare and see what are the other features which is actually seen in the lobular breast cancer in contrast to the ductal breast cancer slides. Then you can correlate these features with the patient's clinical history. So if you have a patient, then you can actually, because we are again training the model right now. So we have the patient story already.
You're training the model, meaning you're giving the data necessary for the AI to make decisions.
Yes,
Okay,
that is
so
exactly correct. We are training the model right now. We are feeding the model or the computer system with the information that we already have. So we can correlate the clinical risk factors of the patient with the risk factors that we see in the actual pathology slide in terms of how the tumor is multiplying, or what are the cancer cells, what are the other cells that is in association with the cancer cells in the slides. Then we are trying to develop an algorithm by feeding the clinical risk and also the biological risk that we see from the actual pathology slides. Then we are trying to incorporate both these risks to come up with a scoring system that we can use to predict the risk of that particular patient to have a cancer in the next 10 years.
So when you do that, that's what you're now developing, the data that will help you create a new scoring system for the recurrence risk. Does that mean that will impact how often and how a woman will be screened over the next 10 years? Maybe more than a year with different types of imaging?
Yes, that is our aim, because right now the risk prediction scores that we mentioned, the oncotype and mammaprint, we know that these are not the accurate test for lobular breast cancer. Because in all the trials which actually helped us to identify the utility of these current oncotype or mammaprint, majority of the patients enrolled in the trial, they are all ductal breast cancer. We are actually extrapolating that data from those trials to utilize that for the patients with lobular breast cancer. So far, we don't have a specific recurrence prediction model only for lobular breast cancer patients. This will definitely help us in terms of the screening, because even if the patient is cured with breast cancer, if we know that this patient has a high risk of recurrence, then we have to keep the patient for a long-term surveillance. Instead of doing mammograms annually, then we may have to think of like getting MRI scans also for the patients, especially if their recurrence is especially if the risk of recurrence is very high. So this will definitely help us in terms of surveillance of the patients.
So is the same with a recurrence as it is for an initial diagnosis? If you catch it, the earlier you catch it, the better the outcome will be.
Yes, that is correct. Whenever there is a cancer, even if it's the initial diagnosis or even if it's the recurrence, and the recurrence also, even if it's a local recurrence, which means that either the cancer is coming in the same breast, or sometimes the cancer comes in the opposite breast, or sometimes in some cases the cancer won't even come back in the breast. Sometimes, unfortunately, it actually comes in some other areas such as the bones or liver.
Because it has metastasized through the
Yes.
lymph nodes somewhere else and it's been dormant for a while and then decides to come alive.
Yes, that is correct. We call it as distant metastasis. So even if it's like a distant recurrence, so basically even if it's a local recurrence or a distant metastatic disease, we need to catch that as early as possible. In the initial diagnosis and also in the recurrent setting, if we identify all this earlier, that means the prognosis of the patients will be good as well, because you can start treatment sooner. And if you're catching the patient with just the local recurrence, and if it's not anywhere in the body, you can just again treat that with surgery and also radiation if the patient did not receive radiation before. And also you can also utilize giving like more chemotherapy or like more anti-hormonal treatments to treat all the breast cancer, so that it will not come back with a metastatic disease.
You earlier mentioned how you're starting to use AI in treatment of breast cancer, which sounds fascinating. So how do you do that?
Sure. So currently I am doing a research which is funded by Pelotonia. So in this research, we are actually trying to identify hormone positive breast cancer patients who are progressing faster in the first line of treatment options. In other words, we mentioned that hormone receptor positive breast cancer is the most common type of breast cancer. although its prognosis is good, if we are identifying that hormone receptor positive breast cancer, if we are identifying that in a metastatic setting or stage 4 breast cancer or a stage 4 setting, the prognosis is not that great. And usually the first treatment option that we use for a metastatic hormone receptor positive breast cancer is a combination of endocrine therapy and a treatment called as CDK4/6 inhibitor. Usually, this treatment will be able to control the disease for almost 1.5 and 2 years because we have several patients who are on this treatment for more than 2 years without progression of the cancer or without this cancer spreading to other parts of the body. But unfortunately, in some patients, we see that we are using the CDK4/6 inhibitor treatment for just 3 months, but the cancer is just progressing rapidly in 3 months. And here we are trying to identify the patients who are going to progress faster when we are giving the CDK4/6 inhibitor by using artificial intelligence. Because here also we are trying to utilize the digital pathology slides that is already collected for the patients. We are looking into the slides to identify what are the factors that is association with the fast progression in these patients. So our hope is that if we are able to identify some signals or some biomarkers which are associated with faster progression by utilizing artificial intelligence, then we can develop specific clinical trials by using specific treatments, particularly to target that high risk feature.
Wow, so it's helping you target when to use the right medicine better.
Yes, exactly.
Wow.
This is what we call as personalized treatment option.
Yeah.
Because now we know that one treatment option might not be the best treatment option for everyone. So we have to identify treatments that is specific for that particular patient. So it's the time for personalized treatment options, and it's the time for targeted treatments, which means that you are particularly targeting that particular feature which is making the cancer progress faster. And in this research we are actually using artificial intelligence to find the pathways that are associated with rapid progression. Because if we identify that pathways with rapid progression, we can develop clinical trials to develop medicines that are particularly stopping that particular pathway which is associated with the progression.
Oh, okay, I see. Got it. Wow. Okay, that was great and very encouraging about how AI is helping you and others, and thank you for being at the forefront of this. But what motivates you to think outside the box, to incorporate AI, to bring new things to your patients?
Sure. I think the main factor that motivates me for continuing the same things that I'm doing right now is my patients. Because I see a lot of patients every day with breast cancer. Whenever they have a diagnosis, they always comes to see us with the fear.
Yeah.
Because cancer is inflicting a lot of fear in patients, even if it's like early stage or stage 4. And we do have treatments for cancer, but again, when it's in the stage 4 setting or metastatic setting, we have only limited options, especially in some particular type of cancer called as triple negative breast cancer or like HER2 positive breast cancer. So here we actually need more treatment options there, and also we need treatments we also need to find treatments which are less expensive also. So here is why we are thinking to utilize artificial intelligence, because so that I can actually give hope to my patients that we can find new treatment strategies for helping the patients to fight with their cancer. And also we can develop more tools to identify the cancer as fast as possible so that we can make sure that the cancer is completely cured.
Okay. Well, thank you for that great work, and good luck as you continue to use AI and develop clinical trials and new and better ways to treat people.
Sure. Thank you so much for having me.
This podcast is brought to you by the Ohio State University Comprehensive Cancer Center, Arthur G. James Cancer Hospital, and Richard A. Solove Research Institute. For more information, check out our website, cancer.osu.edu.